So I'll be presenting our paper, like I said, Trevor Broning, one of the chief residents here, presenting on cannabinoid utilization in fracture clinic, a prevalent study of formulation and delivery modalities. And thanks to all the others involved in that study with me. Advancing slides. For disclosure, the authors of this talk, we have nothing to disclose relative to this. So kind of starting with our questions, a little bit of background that drove this study is in clinic, especially the orthopedic trauma clinic, but honestly in any orthopedic clinic, it's very common now to have patients to ask us questions about marijuana products and what we think about those. And so kind of one of our first thoughts we hear was just how many of our patients are actually using these products? Like how common is this really? Because sometimes, some days it feels like every single patient is asking us this question. And then kind of our other questions then is also, how are these patients understanding how these products actually perceive their effects of pain control? And so that was kind of the impetus for this study that led us to this design. So this is more of a cross-sectional prevalence study, a little bit different than we saw in that Torgham's meta-analysis here. Looking at the right, you can kind of see this larger blue circle, which is our population of interest, which in this case is the OHSU orthopedic trauma patients. So these are the ones we were specifically interested in learning about. And that smaller green circle then is going to be our sample of our participants in the study that we look, and by showing that these are equivalent, we can then basically extrapolate to how many of our population patients are actually using these modalities. Our study period was between January 2020 and February 2021 here. And so once we had kind of the study design, these are the endpoints we were looking for specifically to kind of answer those questions we had thought about. Our primary endpoint here is determining the prevalence of a marijuana use in orthopedic trauma population. That is what that cross-sectional prevalence study is for. And then with secondary endpoints, looking at these patient-reported effects of marijuana product use on both their perceived pain control, but also opioid usages. And just kind of a quick refresher for these kind of prevalence studies, there are no hypotheses or null hypotheses due to study design. It's more of these endpoints that we are looking to address. So moving on to kind of how we designed the study and a little bit of background here. So it was a survey-based study that was administered to clinic patients following their orthopedic trauma injuries that were seen in our orthopedic trauma clinic during that defined study period here. We designed a survey to kind of look at use of pain management modalities. The first half of this survey was designed to look at your more standard pain modalities. So things like oral anti-inflammatories, opiates, acetaminophen-based products, and then more topical agents as well. And for those, we were looking at use as well as how these are impacting patients' perception of pain. And the second half was kind of also to address more of this, our interest here is marijuana-based products. As a kind of reminder here for the term marijuana, it's kind of a nebulous term. It's thrown around a lot in literature and in life. But specifically within this category, there are two kind of compounds of interest that we were focusing on. THC is the first one, or tetrahydrocannabinol, and that's the one that is classically associated with kind of the marijuana effects. It has central nervous system endocannabinoid receptors that it binds to, creating those distinct kind of psychomotor effects we all attribute with marijuana use. Is obviously one of the main active components in it. And the other one then is the CBD, or cannabidiol, which is the other main active component that that is commonly looked at in marijuana. And this one's more of a peripheral interaction. All those endocannabinoid receptors are not centrally based, so you do not get those psychomotor effects. And thus, it's a lot less frequently regulated product here. So for this survey, we designed it to look at both THC use in the products as well as CBD products, their use. Also then to kind of elucidate their impact on these patients' perception of their pain kind of in this post-injury period. The other part of this too that we wanted to look at in the survey is how are the patients using these products? These are substances that can be inhaled, smoked, or ingested. So there's multiple routes of administration, and we wanted to make sure that we were able to kind of look at that specifically with our survey. Going back to cross-sectional prevalence studies, obviously now we have our sample population here. One of the other things we can pull from this is the odds ratio is the more commonly used metric to measure associations, looking at exposures and not exposures, and then outcomes and not outcomes. So in our test group, when you see these come up, it'll be THC, CBD use are kind of our exposures, and then outcomes are things like pain control and opioid use. So one of the important aspects of this is we obviously want to make sure that our study population does reflect the population at large here. So on the left, you see our sample size calculation. The equation there we ran, it showed we need 138 patients to reach confidence for our group, with the Z being a constant, looking at the level of confidence, T is a precision constant, and then P is the expected prevalence, which we use kind of some epidemiologic data to determine that. On the right is kind of the important part. This is our flowchart for the populations that we looked at. That's 737 patients at the top for the trauma population. That's kind of that big blue circle that we looked at a minute ago. So that is the entire population that was seen at OHSU orthopedic clinics in the trauma setting during our study period. We then included 245 of these that were sent then surveys to basically participate in this study. Of those, we had 160 respondents and 85 non-respondents. And then unfortunately, 85 non-respondents was definitely higher than we'd hoped to see. We'll kind of talk about that a little bit later with limitations. So kind of moving on, the next important step of this study from our standpoint was then to show that our study groups obviously were equivalent to then our population at large. And we did this obviously pulling demographic information. So all of our patients were linked to their MRNs. And then we looked at all of the patients that were seen in clinic over the course of this year in our trauma clinics. So that's the 3 different columns. The left one, sorry, it's a busy slide. The left one shows our clinic population as a whole, and then we see the survey respondents and the survey non-respondents, and looking at all these different demographic variables, so gender, different medication uses, treatment, injury location, smoking. And on the far right, obviously shows the p-value, and I think the most important thing to note here is we saw in almost none of these categories there was any statistically significant difference between any of these groups, showing that our survey respondents were similar to our non-respondents, as well as that this whole group obviously was also similar to the population at large that we were studying here. The one thing highlighted in red that we did find, though, was that the injury location had a statistically significant difference. When we look at lower extremity injuries in our survey respondents, it was higher than the other categories. Unclear how that impacted our results, but we did make a note of that. So going on just to our results, these will be fairly simple slides, kind of going back to our primary question, looking at just the prevalence of these medications and usage. This is kind of the baseline for the standard pain modalities. We can look here and see that oral anti-inflammatories, opioid medications, and Tylenol are unsurprisingly very prevalent among our use amongst these patients, with over 80% being used in all 3 categories in this kind of post-injury period. So very common. Topicals a little less so, but they are still being used there. The next slide's simpler. This is just looking at our marijuana products. This is all users here, not differentiating between different routes of administration. We showed that almost a quarter of our patients were using CBD products, but only 15% were actually using THC products in this period of post-injury when we were supplying this survey. So I think this is a slide we'll kind of highlight, and one of the things we found interesting that was one of our focuses as well is within these groups of the THC and the CBD users, we really wanted to differentiate what are the routes of administration that these are being used with. So on the left side, we'll see our THC cohort there with multiple routes of administration being, 2 or more routes of administration that you're using these products. And so we see about a third of our patients were using multiple routes of administration, but the remainder of the patients were divided between multiple single routes of administration. On the THC side, it was smoked and ingested, kind of the more common ones. And then over the CBD, we also saw about a third of our patients were using multiple routes, but then topical ingested tended to be the more frequently used routes, with smoking being a little bit less common there. And we will kind of come back and talk about the importance of this later. So these are kind of looking at our second aim here, looking at the standard pain modalities, really asking, how are patients perceiving this impacts their pain? So it's that kind of red circle there to show a patient-reported improvement in pain following use of these medications. We see the opioids were the most, had the highest percentage of patients feeling that they improved their pain, with oral anti-inflammatories actually being at a close second. But all of the medications we can see had over 50% of patients feeling that they had some impact on their pain with use. Moving to the next slide, this one's a little bit another busy slide to kind of break it down for you. On the left side, we're now looking at our THC users and our CBD users. The top half, we see the THC as all comers, and then we've now divided it down between the different routes of administration, and the same is done for CBD. The obviously red circles highlighting their perception of pain improvement with these different modalities here. We can see the lowest being for the THC at a 71% of users only felt that was beneficial. And then for the CBD group, we saw that it was more topical, had only actually 71% as well. However, all of these were over 70%, so a little bit higher than we saw with some of the standard pain modalities. For here, we ran our odds ratio that for the majority of our routes of administration and for the THC and CBD overall did show kind of a trend towards improved pain control with odds ratio, though we did have large confidence intervals due to the small size. THC for smoked and CBD for topical were the only ones that did not trend in that direction. And then this is another slide. We'd like to hear the left side is just simply one of our survey questions, very simple. We just ask patients directly, do you feel like these substances have any impact on your opioid use? This is a common question, things that have been studied in other studies as well. We see on the left side shows patients that reported decreased use of opioid medications with either THC or CBD, and we see almost 75% of patients using THC thought that this had some impact on their opioid use. CBD was a lot less at 25%. And then obviously on the right, we kind of ran a statistical analysis looking at how this is actually play out, looking at the odds ratio. We see that for oral anti-inflammatories kind of as our looking at one of the standard pain management, and then CBD here, both of those had pretty large odds ratios of concurrent opioid use with exposure to these medications, with a statistically significant confidence interval there. THC trended towards positive with this association, but our confidence interval is not as strong on that, showing that there may not have been as strong of an association between THC use and opioid use, which kind of was shown in that prior graph of how patients feel. And then this is our last slide, just a simple survey question as well at the end, that we asked patients what modality they took they thought was the most effective at controlling their pain. Just as a simple curiosity, we saw opioid pain medications was kind of the most commonly reported, that these patients felt that this was the most effective. Next, we saw the oral anti-inflammatories, but surprisingly, the third most commonly reported medication as effective was THC. So there was, almost 10% of the patients that were feeling, hey, this is the most impactful medication I have taken with regards to my pain management. So going into kind of discussion and to look at this topic and more, this slide is just kind of highlighting the kind of increasing prevalence nationwide of these substances. We look at the lower left, it shows kind of the graph of legalization in the United States. And Oregon was one of the first adopters of marijuana legalization in 2014. And since then, we've now had 17 states that have legalized these substances, with another 19 states that have allowed it for medical or medicinal use. In the upper left, we can kind of see a graph showing use as within Oregon following this legalization. So in 2014, around 11%, and this has climbed up to almost 19% in 2017. And we see a lot of other studies that have looked at kind of at a national level how this legalization has impacted population use of these medications. And all of them have showed kind of a direct increase in the rate of patients use or people using these medications following legalization. And kind of an interesting slide that we found was on the right, it shows per capita of different shops within Portland, Oregon. And we see that coffee shops, so Oregon's known for its coffee drinking. There's 51 shops per 100,000 people in the city of Portland, Oregon. Dispensaries were at 29, and that was higher than breweries at 18. So this is a city where, specifically in our area, there was no shortage of access to these medications. We see patients asking us about it, and we can imagine that looking at all of the trends that are going, it'll be something that's continuing to be used by our patients. But going back to kind of our aim on what is the prevalence of our patient population that are using these in the orthopedic trauma population. Interesting enough, like we said, there was 15% of our patients using this. So it wasn't a catastrophically high number, and was actually surprisingly a little low. When we looked at some of the other data at a population level of Oregon as a whole, we were seeing around that 19% of people were using some sort of THC-based product, which is actually higher than what we were seeing in our orthopedic trauma population. We had 24% of patients using CBD. Those numbers are hard to compare to other metrics because that's not as commonly studied in a lot of the other population-based study designs. On the right-hand slide here, we can kind of look at another study that looked at similar things. This was done by the Harvard group in 2018, looking at Massachusetts-based patients. Also, these were orthopedic trauma patients here that they evaluated, and they had a 14% rate of orthopedic trauma patients that were using THC. And of note, this was in a state at the time that marijuana was not legalized for recreational use. So they actually had similar numbers to us. And we also saw here a trend that at the statewide level and all comers, they had 21% of THC use looking at other studies. So between these kind of two studies, we've seen this now trend that the use within our orthopedic trauma population actually seems to be a little bit lower at the level of kind of the general population at large. Obviously, we cannot make direct associations. This wasn't our study, but something that we kind of found interesting with our results. The other part of this, obviously, is looking at pain management. There's a lot of literature out here looking at marijuana use in pain, specifically a lot in chronic diseases. But within the orthopedic literature, especially in the last 4 to 5 years, there's a lot more papers that are starting to come out with a lot of heterogeneous results. But we do see a lot of these things showing that patients have this perception that it has improved their pain. And we do kind of see this bore out in our study here, that over 70% of our patients felt that all different modalities of THC or CBD use has some positive impact on pain use. in their post-injury period, with odds ratios kind of trending this direction as well. Unfortunately, those were not statistically significant in our analysis. And then we did see some statistical association between CBD and NSAID use in opioids. We did not find that within THC there. And so kind of this next slide will highlight as well. This is kind of looking at the routes of administration that we evaluated. And I think this is one of our more interesting things and kind of the big takeaways from our paper that we found interesting is when you look at a lot of the literature out there, especially in the orthopedics and in other fields as well, when they look and study marijuana use, they study marijuana use versus non-marijuana use. And unfortunately, that creates a very heterogeneous group here. As we've looked at here, there's THC and CBD containing components of the marijuana products, as well as products that have either one, the other, or both. And then as well with both of these products, there's multiple different routes of administration. And when we look at like the pharmacokinetic studies, we know that the, basically peak plasma concentration and length of action and whatnot of these compounds is variable based on what route they are administered on. And so when we look at our patients, we have a third of them taking multiple routes for these medications, but the remainder of them are taking only a single route that is divided between smoked and ingested for our THC group, and then topical and ingested for our CBD group. And this can have a significant impact if you're running a study designed to look at how marijuana has effect on, pain control, fracture healing, any other metrics. If you're studying it as a population as a whole, you may not be getting accurate data. I think it's very important, and something I want to highlight in our paper is obviously the importance of looking at specific routes of administration as you discuss this, because that'll create a more accurate assessment of what you're looking at. So looking at our study design strengths here, I think we showed, our study group similar to the general population. Looking at our demographic analysis, we achieved our sample size calculation, and we were able to look at this, variability in the modalities of administration here. Some of the limitations, I think, one of the big ones is our low survey response rate. We only had 85 patients, or we had 85 patients that did not respond to our survey. Unfortunately, during the period of time of the survey administration, obviously was also concurrently with the COVID pandemic. And so there's a chance that unfortunately that played an impact on this. And the other thing too is during our survey, when we started, we initially used paper surveys. We transitioned to electronic surveys as well for COVID. And so that route of administration may have had an impact as well on how patients responded to the questionnaire. We don't really know how that had an impact, but that is another concern with the limitations of our study. So overall, for a conclusion of our study, this is a cross-sectional prevalence study looking at the rates of use within our orthopedic trauma population. We did see use about the level of the general population at large within the state of Oregon here, with multiple routes of administration. And we do continue to see this very strong association between use of these medications and pain management. And so I think it's a topic that as providers will continue to see patients ask us about. We know that the use is increasing nationwide. Unfortunately, the literature is still very heterogeneous on this, and I think there's a lot of unanswered questions that should be continued to look at. And I think the important part is as we continue to address this thing, it's important to make sure we specifically focus on the compound of interest as well as how are they taking these medications. That's all. Thank you.
Okay. Ken, can I start the meeting?
Yeah, go for it. Thank you, Trevor.
Yeah.
So first off, Trevor, that was an outstanding PowerPoint presentation. Thank you. Beautifully delivered, beautifully prepared, really, really well done. So if you have a piece of paper and a pen handy, I can give you sort of a quick rundown through the paper of all the notes I made, okay?
Oh, that would be fantastic. I will be typing, so please ignore me.
Okay. So first off, I get the whole hypothesis thing, but you still need to always clearly demonstrate the aim of your study. The purpose of our study is, the aim of our study is, and if there's twofold, then it's 1/ and 2/ and 3/, okay?
Of course.
So that's not in there. For me, it's the most important thing for me when I started reading this paper is I had one question. And the question is, does marijuana use decrease opioid need? There is an opioid pandemic in this country. And I think that you need to beef up that concept throughout the entire paper. And when you're reading this, the real clinical relevance of this study is, did it decrease opioid consumption? Okay, for me, I mean, just looking at this.
Yeah.
So in the methods section, it doesn't say that, even though you asked it in the survey, in the abstract, in the methods, it does not specifically state, did the use of marijuana decrease opioid use? And to me, that's got to be everywhere in this paper. Okay. Same in the results. It's not mentioned in the abstract. Same in the conclusions. It's not mentioned in the abstract. Okay, so then in the introduction section, again, you have to have a paragraph that clearly states the aim of the study or the purpose of the study. In the introduction, sorry, in the methods section, the power analysis is the sample calculation was awesome. I mean, that's like really, really good. And then again, in the methods section, you talk about, finally, we ask patients which modality was affected, but again, not mentioning, did it decrease the need for opioid use? That's what's going to get this paper in.
Perfect.
In the results section, when you talk about the 160 out of 737 potential patients, there should be a percentage there. Okay, because that's like 21%, 22%. So, I think that's important to put the percentage in.
Yep.
Okay, the demographic stuff was good. Okay, so the figure 2, so the prevalence of use, to me, the minute I saw this figure, I wanted to see the figure for the marijuana use, which was in a separate table. But what you could do is have the marijuana use just not separated out right there, so that we see the prevalence of use of all of the medications combined. And then in your table 2, you have the specifics of your prevalence of use and impact and pain. But again, I don't see anywhere where it says, it was in the presentation, and maybe I missed it on this table, the impact on decreased opioid use.
Yeah.
Okay. Okay, then, no, this we already talked about. Oh yeah, so here we go. The THC group had 75% reporting its use led to a decrease in the opioid consumption. I read this like, hallelujah. Okay, there's the information I was looking for. And that obviously needs to be everywhere in the, for me, it should be in an aim of the study. Okay, so what's the overall prevalence? And 2, did it decrease the risk of opioid consumption? Because that's such a huge thing right now in the US. And that should be followed all the way through in the purpose, in the methods, in the results, and in your conclusion. Now, in the discussion section, my preference is for the authors to always start this discussion with the following words. The key findings of our study are, okay?
Yeah.
And then once you do that, then you list on how your study differs from other studies, and you break it down into categories, whether it's mode of transmission, whether it's prevalence compared to other states, whatever the things you studied, you do paragraph by paragraph on how your results match up or differ from other results. Okay. In the paper, you don't have anything on your study strengths. You had it in your slides. But maybe I missed it, but I don't see anywhere where the strengths of our study. You have the limitations, but I couldn't find it well outlined, strengths of the study. Okay, and then again, in your conclusion, the conclusion should start with the key finding or the main finding of our study is, and then from there, it's a sentence on clinical relevance. Okay, and for me, you did that really well in the last sentence, but you needed to put in the decreased opioid use. And then your citations, I mean, your citations need to be beefed up. Okay. And I think that if you add a whole section on opioid consumption and the pandemic in the United States, epidemic, whatever you want to call it, that'll beef up that whole citations really well. And That was it. Okay.
Excellent. Thank you. Appreciate all those.
Hopefully that helps, but I think that'll really strengthen your paper because you documented that it was decreasing opioid use. One by 75%, one by 25%. That's massively important.
We will make sure to highlight that. I look forward to you reading this published someday. Thank you for your help.
There you go. Oh yeah, this will get published. It just needs a little tidying up. That's all.
I appreciate it.
Yeah, the design, the statistics, everything was beautifully done. Very, very well done.
Okay. Thanks.
Excellent. That was fantastic. Great. And like for all the residents and everybody listening to have a deputy editor at Core and these insights are like so valuable and great. I mean, I'm taking notes. This is fantastic. Thank you so much. And congrats, Trevor.